Morning, Susan.
Good morning, Dave. Can you hear me okay?
I can hear you. Great.
Okay.
I assume the same for me.
You sound great. Nice cool morning as opposed to the hot last week.
August.
Yep.
Well, I know there's other people here, but I'm glad we got to go to last night's meeting. That was nice. It was really good.
It was really great.
Great discussion.
I'll remind folks that it's posted on our website. Good morning, Elena. Do you want to do a sound check?
Sure. Good morning. Can you hear
Good
me?
morning. I can hear you fine. Can you hear me?
I can.
I'm a little paranoid about my sound quality. Jessica, can you hear me okay?
All good.
Okay. Morning, Dr. Hammery. Nice to see you.
Good morning. Nice to see you guys. Looking forward to learning a lot here.
Morning, Susan. Can you hear me and see me okay?
Yes, I can.
Teams, it looks like didn't update. That's confusing me. I see Robin, Tom, Jess, and Dave. Okay. And is Elena here?
Yes, she is.
All right, great. I'll call to order the Green Mountain Care Board's hearing of August 6, 2024. Today is the beginning of the hospital budget review session.
This is the court reporter. Are you ready to go on the record?
Oh, sorry. Yes, can we go on the record, please?
One sec. We are now on the record.
Thank you. I'll call to order the Green Mountain Care Board's hearing of August 6, 2024. Today begins the hospital budget review session. We have an overview of the fiscal year 25 hospital budget request from the Director of Health Systems, Finances, and Policy by Elena Barabee. And then we have insights being presented by Tom Reese, relating to certain Vermont hospital financials. First, I'll turn to the meeting minutes from July 10th, and I will move for approval of the meeting minutes from July 10th.
Second.
All in favor of approval, say aye.
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 Aye. And the meeting minutes are approved. And I'll turn to Susan Barrett for the Executive Director's report.
Good morning, Chair Foster. We have several open public comment periods. The first is related to today's discussion, and that is the FY25 hospital budgets. That public comment period opened today, and we'll be taking public comments through August 30th, noon on August 30th. I do want to say we take public comments at any time, but this is a special public comment period for the FY25 hospital budget. In addition, we're accepting public comments for the second phase of the community engagement regarding hospital sustainability. We've received many comments. Please keep them coming. They are informing our contractor, Dr. Hammery and Oliver Wyman, as they finalize their report on hospital sustainability. And I just wanted to put in a plug for a meeting that we had last night, which was virtual, and folks can look at that. And if you're not talking, could you mute? Thank you. On our YouTube channel, please check that out. It was a really robust conversation. It was the overview of a statewide presentation by Dr. Hammery and Oliver Wyman on hospital sustainability. Any of those public comments that we receive on Act 167 and hospital sustainability, we are sharing with the Agency of Human Services as they are leading the transformation on this project. So please keep them coming. And then last but not least, we are accepting public comments on a next all-payer model, a potential next all-payer model, as we work through those negotiations. Please keep those public comments coming, and we also share those comments with the Agency of Human Services as they are leading the negotiations on the potential ahead model. And with that, I'll turn it back to you, Mr. Chair.
Thank you very much. I have nothing else other than to turn to Ms. Barabee for her presentation and overview of the budgets.
Great. Thank you. All right. I will share my screen. Let me know if you can see it. Good. Okay. And I will be joined by Mark Hengsler, who is one of our staff attorneys when we get to the kind of the statute and rule background. So I just wanted to say that. So I'll go through a brief background. I'll turn it over to Mark, then we'll kind of do a brief reminder of what we established in guidance earlier this year. And then I'll run through a summary of hospital budget requests. And then we can talk about next steps. So some background information. I'm going to breeze through these. You've probably seen these in various forms many times, but just as a reminder for folks who are joining us for the first time, Vermont has one of the highest spending per capita among all states in the country. And we know that our country as a whole is doing pretty poorly in terms of how it's controlling its healthcare spending compared to many peer countries. In the 1990s, we were kind of among the lowest spenders per capita, and this has dramatically increased in more recent years. Really starting after 2010, we've kind of hung out at the top decile rankings amongst all states. And as you know, one thing is, if you look regionally, New England is one of the higher regions for healthcare spending per capita, but Vermont remains kind of among the highest, even compared to our peers, only surpassed by Massachusetts, which is also known for its high spending. And this is translating into higher premiums and is creating real affordability challenges. I think this is a slide we're all familiar with, particularly in light of recent discussions, we're seeing higher than national average growth. We're already higher, and that might be well and good. We're providing, better benefits than some other states, but our growth is really astronomical compared to comparable states. If you look from 2019 to 2024 compared to other New England states, Vermont has had the highest growth in premiums over that period of time. And some may say that age has a lot to do with this growth factor, but what we see is Vermont is kind of middle of the road compared to our New England peers. And so age alone does not explain this trend. There's something else kind of going on. It's not all just the QHP market. It's also in employer-based insurance premiums. We're seeing similar growth. Unfortunately, this stops at 2022. We know there was some substantial growth since then, so this probably is only going to look worse. To date, there's been kind of limited transferring of that premium to the employee. Employers have been bearing the brunt, but there's probably limited returns there, and they're also foregoing kind of wage growth and other things that we've heard anecdotally are happening as a result of this healthcare spending growth. As this has not looked good over the course of recent years, and so growth is really big right now, and we have some decisions to be made about where we go next. Hospital spending is a major component. So at national level, we're around a third of spending is really on hospital care. This is one area that we look to control spending growth. In Vermont, it's much higher than many other states. Around half. This isn't kind of apples to apples, but there is kind of a spread that is interesting to look at.
Sorry, Miss Barabee, can I interrupt for just a minute? I got a note. Miss Barrett, are there people in another link?
Yes, I got a call from someone where there's a faulty link. So the correct link is on the monthly meeting agenda. I can work with Kristen to correct that if we can just pause. There's quite a large group in another meeting.
Okay, we should probably
Sorry.
address that. Why don't we just take, I'm sorry, Elena. Why don't we just, we'll take a break for 10 minutes and come back to this link, Susan? Okay, so we'll resume at 9:20. Thank you.
Thank you.
Susan, did everything get worked out?
Yes, it did. Thank you. I apologize for the delay.
No problem. And Maggie, are you here?
Yes, I am.
Great, okay. We'll go back on the record and resume. So thank
Yeah,
you
back
for the,
to the record.
Great.
thank you.
So I should pick up where we left off. So we're talking about how hospital spending is a major driver of healthcare spending. And in our state, we spend almost half of our healthcare expenditures on hospital care. And one reason for this could be that we have really great access or we're using a lot of services. When you look at the Dartmouth Atlas data, that doesn't appear to be the case. This uses Medicare claims to look at volume of service delivery and intensity of service delivery. And there's usually a high correlation between volume in one payer and volume in another payer, just in terms of provider trends and organizational trends. And so there is quite a, so it's not, exact, it doesn't have all payer, but it's a really good indicator of service use. And what we see is when we look at hospital admissions during the last 6 months of life, Vermont is one of the lower states. When we look at price adjusted total Medicare reimbursement, so that's kind of total volume of services, we're also among the states with lowest volume. When you look at cost report data and you look at adjusted patient discharges, so this is a measure of inpatient, outpatient volume that's supposed to get kind of more apples to apples across hospitals. Our utilization has looked relatively flat and quite low compared to other states, particularly this is looking at New England states. When we look at the NASHP cost tool, again, you can kind of see over time, we're kind of on the lower end. We're a smaller state, so that makes sense. But our growth has been, pretty flat, similar to other states, with the exception of 2020 when there was a dip for all, really most states. And then if we look at hospital admissions per 1,000, again, we're on the lower end. So we're just kind of triangulating lots of different ways of looking at the data, and there's kind of consistently on the lower end of utilization. We look at BUDS data. So this is the hospital discharge data that the state maintains. And unfortunately, we weren't able to get newer data, but it's been pretty flat since 2017 to 2021. It'd be great to see these data updated as we move forward and kind of tracking visits and discharges over time. So, when we look at the volume data, not a lot of rationale for a higher spending. When we look at operating expense growth per adjusted discharge, Vermont is among the highest compared to New England peers, only second to, in this case, Maine. This is using NASHP hospital cost tool data and looking at operating expenditures at the state level per the state level adjusted discharge. This is effectively kind of like a state average. It's not a hospital median. It's really looking at all the all the volume across the state. And so you can see from 2012 to 2022, we're, right there at the highest level of growth in terms of costs. And these costs translate into higher prices, and I'll not go too deep here because we'll have a presentation this afternoon from the folks that pulled these data together. And Rand is going to speak with us about the latest pricing analysis. But what you can see is Vermont tends to be kind of at the higher end in terms of its prices per service. So this increasing operating expenditures kind of translates into higher prices. When we kind of dig in a little bit, this is looking over time for some of our academic medical centers serving our state versus our independent critical access. We kind of lump them together to look at averages. So this is looking at relative prices compared to Medicare. So what is your commercial price relative to a Medicare price, as well as a standard price? So what is your kind of average adjusted price per service? This is looking at inpatient services, and what you'll see is our critical access hospitals tend to be a little bit on the cheaper end, while our academic medical center tends to be on the more expensive end. Dartmouth Hitchcock is another academic medical center, and they seem to be more affordable on these statistics compared to UVM. Rutland is kind of on the cheaper end as well, or more in between Dartmouth and UVM. Southwestern Vermont is also kind of on the higher end, but yeah, so it just depends what year you're looking at. When we look at outpatient services, we see a similar phenomenon. In critical access hospitals tend to be on the more affordable end, and our academic medical center tends to be quite expensive, almost in 2022, almost at 400% of Medicare. So I want to talk about some other trends that are happening. Medicare Advantage, there's increased penetration in our market, as there are in many markets, and this affects how hospitals get reimbursed. We're looking at public payer rates. So Medicare will see a 2.9% rate increase. We're expecting in our PPS hospitals. Critical access hospitals will continue to receive kind of a cost plus reimbursement. Medicaid will have a 0%. We understand 0% increase this year in terms of reimbursement. And we, it's hard to kind of find the budgetary impact. So we have some questions out to hospitals on the impact of New York Medicaid rate increases, but they did increase their appropriations for hospitals. So we would expect to see some increase there. I'm just not sure how much. So, there's not huge reimbursement increases from our payers. We know that Medicare Advantage is really kind of more along the lines of a capitated payment and don't always pay super well. We're going to continue to have labor expense growth. So, there's no end in sight in terms of operating expense growth, and we'll kind of look into the details soon. Pharmaceutical spending is expected to continue to grow into the near future, from 4 to 7%. This is a national analysis put together by IQVIA, who kind of closely monitors pharmaceutical spending growth. And so then while some protected brands, the prices will decrease, some of the list prices will continue to grow. So, how this shakes out is, consumers are going to continue to experience kind of the higher level of price increase. And then depending on how those reimbursements and discounts work, those discounts will get spread out across the provider system. AI is another thing that, we know that's being implemented. It affects the way care is delivered. It affects what care is delivered. There's decision support tools, diagnostics, treatment recommendations. It affects kind of what services people are recommended and how we code acuity of patients. And so, this is another area to watch over time as we learn more about how that is impacting healthcare spending and care delivery. When you look at the Kaufman Hall National Hospital Flash Report, so this is really looking across the nation, across regions, many different kinds of hospitals, for-profit, non-for-profit hospitals. They kind of summarize some key takeaways. So June of this year, things are looking definitely more stable than they have in the prior year. There's a growing divide between high-performing hospitals, those that kind of can manage cost growth, and low-performing hospitals, those that can't really manage cost growth or kind of struggling with volume. 340B is another kind of area that continues to kind of expand, and some hospitals are taking advantage of those rebates. And I think those are the kind of key points. I just want to point out, we're not alone in being concerned about healthcare spending and healthcare spending growth. There are a lot of other states that are trying to kind of control healthcare spending. A lot of them start with kind of a total cost of care growth target, and some are getting more in the weeds on either reference-based pricing or hospital price caps, hospital global budget, so other ways to kind of control and target hospital spending. And I believe Delaware just recently passed some legislation that would mirror some of our regulatory processes and hospital budget process. So there's kind of an uptick on interest and level of scrutiny on hospital spending. At the same time, I think, this is not news to folks. We also struggle with kind of rural hospital financial health and the threat of rural hospital closures. 192 rural hospitals have closed since 2005 across the country. So it's not just that, our hospitals are super healthy and they're raking in the dough. There's also kind of this challenge of, financial viability, particularly for some of our smaller hospitals. And more than half of U.S. rural hospitals are at risk of closure when you kind of look at their operating margins. So again, we're not alone here, but we're definitely, if you kind of look across the country, we're in the middle to severe end of the spectrum. So why is that the case? I'm not going to spend too much time, but just want to remind folks, we have declining patient volume, higher costs associated with maintaining access to low volume services. It's really hard to get in economies of scale when you have rural populations. We want to make sure that we have care where we need it for everyone, regardless of where you live. But we have to think about what the costs of maintaining those kinds of infrastructure are. Inefficient operations or low provider productivity could also lead to struggling financial position. So, if you're not able to serve patients and bring in reimbursements and maximize your provider time, that might lead to access challenges and financial challenges if you don't have other ways of bringing in revenue. Administrative cost growth, so non-productive staff or staff that don't bring in revenue is also a challenge. Fixed costs that are too high given variable patient volume or unreimbursed borders and transfers that could be better served in other settings that aren't necessarily reimbursed within the hospital setting. So that's another kind of access-driven challenge and could lead to financial challenges. Insufficient Medicaid reimbursement, assuming services are delivered efficiently, we may not be appropriately covering the cost of care delivery. Provider bypass. So sometimes we do have a hospital in our backyard. We could bring our healthcare dollars there, but we choose to drive further for care, either to a neighboring community or even out of state. And that brings spending. Even though that spending still affects our premiums, it doesn't actually end up in our facilities in Vermont. And then our rural healthcare workforce shortages and recruitment challenges often lead to a higher cost of labor. So just having so many vacancies and so much competition can drive up labor spending and costs. So I think we started off with mentioning the community engagement work and all the great discussions that have been had. I think I just want to highlight this work because hospital budget review process is one tool, but it's certainly, the reason why we started this engagement work to begin with is because there are kind of limits to what we can do within this process if we're really going to solve this problem. So just recognizing that the decisions made here won't necessarily solve all of our challenges, but are trying to move us in a direction. So why should we regulate hospitals? So we mentioned higher hospital spending is a major contributor to unaffordable health insurance premiums and out-of-pocket costs. This has real implications for Vermonters. Higher spending in one sector, for example, hospital spending, could limit resources that could otherwise be allocated to other parts of the delivery system. We know that primary care, mental health, and other preventative services and social services are areas that are grossly underfunded and can have huge impacts and benefits for Vermonters. We also know that spending money on healthcare limits spending that could be happening in other parts of the economy. So, financial health debt and health burden kind of has ripple effects across our communities as well. So Vermont's healthcare system is highly concentrated and there's not, it's very localized as well. So regulation is essential to contain monopoly markets, and this is particularly salient in rural settings when we don't have as much competition. And it's not as easy to get, go to the other hospital down the street. It's kind of a bigger lift to kind of make it to somewhere else. And oftentimes you may not even have a choice, right? So you're going to go, if you're seeking out emergent services, you're going to kind of go where you need to go when you need to go there. So our process has been around for a long time. I won't spend a lot of time here, but it has evolved. But the main goal of constraining and kind of controlling healthcare cost growth has been at the forefront, and making sure we maintain access to care is another key objective. So I'm going to pass it over to Mark to take us through this next section, and then I'll pick it back up in a minute.
Hey, good morning, everybody. Nice to see you. I think that between Elena's engaging slides, I'm tasked with being the laborious middle, but we're talking statute and rule, and really what I'm hoping to get across briefly here is the question of what is the board tasked with doing, and then how is the board required to do that? You can go ahead to the next slide, Elena. So as a background, each year the board must establish a budget for each hospital by September 15th with a written decision by October 1st. When establishing a budget, the board relies on its statutory charge and the state's regulatory objectives. And what I'll do in a moment is just walk us through those so we're all on the same page about what the scaffolding is. In this process, hospitals bear the burden of, well, if you pop back the other slide just for a moment. Yeah, they bear the burden of persuasion in justifying their budgets as submitted. And if a hospital doesn't meet its burden of justifying its proposed budget, the board must adjust the budget so that it aligns with the state's regulatory objectives or regulatory goals. And go ahead to the next slide. So when reviewing a hospital's budget, there are a few parts of statute that come into play. First, there's the board's statutory purpose and charge. Second, the board's duty to regulate consistent with the principles for healthcare reform. Third, its obligation to establish budgets using considerations that are in the hospital budget review statute. And then fourth, annual benchmarks that the board establishes against which proposed budgets are initially evaluated. I will go through each of these in a bit more detail right now, and my hope is not to lull you to sleep. It really is to demonstrate what I believe is very consistent messaging from the statute throughout about what the board is to be looking at and how this all fits together. So go ahead to the next slide, please. First, we have the board statutory purpose and charge. So this is direct language from the statute. It's the intent of the General Assembly to create an independent board to promote the general good of the state by 1, improving the health of the population, 2, reducing the per capita rate of growth in expenditures for health services in Vermont across all payers while ensuring that access to care and quality of care are not compromised, 3, enhancing the patient and healthcare professional experience of care, 4, recruiting and retaining high-quality healthcare professionals, and 5, achieving administrative simplification in healthcare financing and delivery. So that's the overall job of the board. Next slide, please. With that in mind, the board regulates consistent with principles for healthcare reform that are also defined in statute. The board has to execute its charge consistent with those principles, and there are a number of them, but some relevant ones in part are listed here. I'll read them out. 1, universal access to high-quality, medically necessary health services. Systemic barriers such as cost must not prevent people from accessing necessary care. 2, health costs must be contained. Growth in spending must balance the needs of the population with the ability to pay for it. 3, primary care must be preserved and enhanced. 4, the system must be evaluated to improve quality, safety, access, and cost containment, including efforts to promote healthy lifestyles. And 5, unnecessary expenditures must be eliminated. This includes administrative costs that do not contribute to efficient, high-quality services or improve health outcomes. If you can go to the next slide, please. So with that scaffolding in place, the specific hospital budget review statute lists a number of considerations for the board. And as we go through these, you might notice that there are some ways that these items attach to some of these concepts of cost containment and access and quality that are discussed in those previous slides. So specific to hospital budgets, the board considers, and this is not an exhaustive list, Vermont's critical health needs and resources, actual hospital performance with respect to past budgets, utilization info, hospital administrative costs, salaries for hospital leadership, hospital salary spread, and a comparison of median salaries in New England, the extent to which, if any, undercompensated costs are charged to the commercial market, hospitals' investments in workforce, reports from professional review organizations, public comment, and then the benchmarks that are established by this board. If you can go to the next slide, we'll just turn briefly to the benchmarks. So under statute, the board may establish benchmarks. These are a process to define on an annual basis criteria for hospitals to meet. There are a number of examples of what benchmarks can look like. And what Elena is going to do in a moment is turn to those and describe what this year's benchmarks are. The board establishes benchmarks for hospital use in developing and preparing budgets. And in doing so, GMCB staff meet with VAWS and meet with the HCA and obtain input. And then benchmarks are provided to hospitals by March 31st. Benchmarks help the board consider whether budget adjustment is necessary. Benchmarks are not the statutory objectives or requirements. So they're a tool, is a way to think about them. And then go ahead, please, to the next and I believe final slide. So if we just kind of break this out as a very simplified overview of what's here, the board is tasked with establishing hospital budgets that meet the state's objectives that are described in statute. And these objectives consistently tie back to increasing access, improving quality, and containing cost. There are some other things in there, but those are three pretty big themes throughout the statute as far as I can see. Each year, the board establishes benchmarks to focus its analysis and to aid discussion with hospitals. It establishes budgets using the objectives in statute. It doesn't establish budgets using, it doesn't establish budgets by just setting them to the benchmarks, but the benchmarks are really useful tools in evaluating what the board should be looking at. Each hospital, again, bears the burden of persuading the board that its proposed budget aligns with the state's regulatory objectives. And in the end, that's the thing that the board is making determinations about. And that's it for me. So I'll go ahead and turn it back to you, Elena.
Great. Thank you, Mark. All right. So then we'll just do a brief overview of guidance. So just a reminder of where we are in the process. So the hospital fiscal year begins October 1st, but guidance is really issued for that year in March. So you guys wade in, kind of explored a variety of metrics and established that guidance. In March of this year, we issued written guidance and hospitals had until July 1st to work that guidance into their budgets and consider it before submitting their materials on July 1st. We actually extended that to July 8th this year. I'll talk a little bit about that. And then we have to approve, modify, or deny budgets by September 15th in order for that October 1 fiscal year to commence. So I just wanted to do a brief reminder of where we are in the process. We in the guidance established this decision tree to help guide how we're thinking about reviewing budgets. So again, as Mark mentioned, these benchmarks are kind of step one. We set 3 benchmarks this year, which I'll talk about in more detail. If the hospital meets the benchmarks and staff kind of look at the budget assumptions, are they reasonable? Are submissions complete? And are they timely? And then, we'll either recommend to approve the budget or consider adjustment. If the benchmarks are not met, we still look for budget assumptions to see if they're reasonable and if the budget makes sense to us. And again, are they complete and timely? And then we may dig in a little bit more and ask questions and review hospital justifications, which were required in Section 1 in more detail. And we still may, determine that the budget may not meet the benchmark, but we may still recommend approving it, or we may consider budget adjustment. And then regardless of whether or not the budget is approved, there may be other kind of opportunities for hospitals to be forward thinking about what they can do to continue to improve. This isn't kind of a one and done. We're expecting that, change takes time. Affordability and improving affordability, quality and access takes time, but we need to kind of understand where hospitals are going and how they're thinking about helping us solve these real challenges. So this year's hospital budget guidance set 3 benchmarks, as I mentioned. The first one is the net patient revenue. It capped no more than 3.5%. This is the total amount of revenue that a hospital receives for delivering patient care. So this is a sum of all payers, Medicare, Medicaid, commercial, et cetera, that they would receive from operations, from delivering care to patients. And that is in line with the 3.5% that's set in the Vermont All-Payer Model Agreement, which is essentially our state's total cost of care target, and what we've committed to do to try to control healthcare spending and get it more in line with economic growth. The second benchmark we set is for commercial rate growth, which I think what I've noticed over the past couple of weeks from working with various hospitals and other folks is that this word rate can sometimes be confusing. The intent here, and as was spelled out in guidance, is really about controlling prices. So we know that commercial prices are often higher in order to kind of subsidize that cost growth, where other payers may not be keeping up, or kind of granting the same kind of pricing reimbursement or price increases to accommodate that price growth or that cost growth. And so this year we said, we want the commercial price growth to really, or reimbursement growth to be no more than PCE price index plus 1%. This was an inflationary measure that was akin to kind of like a CPI, but made the most sense and was kind of smooth for all over time. And so that was 3.4% based on the data that we had at the time. And then we wanted to make sure that, you met those two things and that you were still achieving a positive operating margin. We didn't weigh in on exactly what the right operating margin is because it may look different for different hospitals. And so we said we just want to see it greater than 0. And there may be good reason to be, slightly above or more above that amount. And then hospitals not meeting these benchmarks were required to justify with evidence why they needed more than what we established in guidance. And there were particular requirements for each of these where we wanted to see productivity information. How are you maximizing the use of your existing resources? Are you kind of bringing in and recognizing all of the revenue that you have opportunity to recognize, et cetera? Are you managing costs to the best of your ability? Show us how. And so those are the kinds of things that we'll be looking for this year from hospitals to justify those requests. Okay, so I'm going to kind of go through what we have so far. This is going to be high level overview, and then, our hospitals will each present their own budgets over the course of the next several weeks, and then staff will kind of come back and pull from what we heard from hospitals, as well as kind of dig into their financial metrics in more detail. So, there will be more data coming out as we kind of get that up and running, but I'll kind of revisit that at the end. Okay, so the first thing, so I mentioned that our our deadline for submitting budgets is July 1st. This year, we extended that to July 8th because we got one of the kind of important templates out later than we anticipated, and we wanted to give everyone time to digest that and ask questions. Even with this deadline and the extension, 2 hospitals submitted major updates to their budget after the deadline. One, and this is not a name and shame, I'm just kind of calling out process because I want everyone to be aware of kind of what the challenges were. And this is still a moving target. We still don't have all the pieces of some of these budget requests. So SVMC was unable to negotiate a higher Medicare reimbursement rate, so they resubmitted their budget on July 24th. UVM, though they notified us that they wanted to request a higher rate due to higher than anticipated costs with bargaining. They resubmitted their budget documents starting on August 2nd, and some of them came in yesterday. So I really did my best to incorporate the latest data I have, but that doesn't really give us much time to analyze and do kind of a deep dive. So we're really stuck being at high level here, and then we'll have to go into more detail. There's some feedback. Okay. Thank you. All right. So, I think I mentioned this deadline challenge. We're still waiting on some resubmission. So we've been going through and kind of checking and making sure all the materials make sense to us. We're still waiting on a couple items from some hospitals and more from others. And so I think I just wanted to plant this here for kind of future thinking, how can we really make this process as seamless as possible so we have the best information by July 1st so we can actually kind of spend time looking at it. We're thinking about June office hours, templates for budget assumptions. If we recognize that a budget is just a budget, but at some point we have to draw a line in the sand. So if staff and the board can understand more, what are the assumptions in the budget and how those might change, that might be one way to get around this resubmission of budgets. And then I think proposing to have some kind of mechanism that, if we don't get the information we need or submissions are not timely or complete, you may just get a level funded budget. It's a huge administrative burden to be chasing down all the materials. Anyway, I just wanted to say that it's something we're thinking about, but it affects the quality of the analysis that we can do. So if I'm going to summarize the budgets that came in, you'll notice, so this is each of the benchmarks, the commercial price benchmark, the NPR growth benchmark, and the operating margin benchmark. You'll notice all the way on the right looks across all three. None of our hospitals met all three of the benchmarks, which means that they're kind of all right for a deeper dive. And so you'll see is that some kind of did better on the commercial price, but then they made up for it on the NPR growth. So it could be coming from volume, it could be coming from somewhere else. But those operating margins are generally close to or meet the guidance, with the exception of Grace, which we know they get some donations, and so at a total margin they may look better, but their operating margin may look lower. So we feel better about the operating margin, but then we really have to dig in to hospital assumptions and make sure that those operating margins seem reasonable and achievable. When we looked at kind of the impact of these budget requests on the total, you'll see the system growth year over year, based on the best available information we have at this point in time, looks to be about 8%. So we set guidance at 3.5% for NPR growth. System-wide growth is really about 8%. Commercial price growth at the system level this is kind of the impact of the price growth on NPR, looks lower. So we'll dig into that further. But when you look at the percent of NPR growth driven by commercial price versus non-price, you'll see that 33% of that overall NPR growth is driven by price, and 66.7% is driven by non-price. So predominantly utilization. You'll see that 4.2% in the middle there is really system-wide volume growth assumptions. Okay. And this is based on data submitted as of yesterday. So we're still kind of error checking, and there are some that look still a little bit different than what I would expect. So this may evolve as we learn more in the coming weeks. This is looking at price versus non-price components of just the commercial component of NPR. So this is important because this is what translates kind of directly into commercial premium growth. So you'll notice that the system year over year grew in the commercial revenue sector by 9.6%, 5.4% from commercial price, 44.2% non-price. So if you look all the way to the right, as a percentage of the commercial NPR growth, 57% of that growth comes from commercial price, and 43% of that comes from non-price or volume. So when you're thinking about premium growth, prices are important, but you also need to think about volume growth. So those are kind of two levers that folks have to increase reimbursements. This was another version of a slide that you saw earlier this year. So really thinking about, NPR growth over time. In 2017, so this is looking at if we took 2017 and applied a 3.5 or 4.2% growth factor, where would we be? We're substantially higher than where we would have been if we kind of kept to that 4.2 or 3.5%. We said 3.5% this year. Even if you give guidance, we're still going to be over that over this period of time because of the more recent kind of increases that we've allowed in 23 and 24. So you'll see this bar chart all the way to the right. So that's looking at FY25, the guidance versus what was requested. And so I think the colors may be swapped there, but the top line is what was requested, and like the next line is what was established in guidance. So the requests are higher than guidance. Also for FY24, you'll see that the projected is outpaced the budget. And so, we're already kind of overshooting here, and then we'll get back to enforcement for FY23, but we did have some overages in FY23, which is why we think it's really important to look at these budget to budget when you're thinking about system level growth, and then understanding how you get from budget to actuals and trying to have a conversation about when that's warranted or not, and then how do we model growth going forward. So if you look over this period of time, compound annual growth has been around 6%, which is quite a bit higher than the 3.5% that our state has been aiming for quite some time. So this is looking at, hospital financial health is also very important. Operating margin and total margin. We included EBITDA margin, which is kind of in between. It adds back depreciation, interest, and other things to kind of get a more of an operating picture. And so you'll see, some of our margins, our operating margins are quite negative, but then, with total margin, things are looking better using our projected data, though our 23 actuals were not so great. But our FY25 submitted budget, as in terms of total margin, everyone is expected to be over that 0%, which is helpful, but still some concern of some that are really hovering around 0. That doesn't give a lot of room for error. And then if you're relying on investments to kind of get you over the line, that's also tricky if the market doesn't do what you expect. So you really want to make sure that your operating margin is solid, so that you don't have you're not subject to kind of the market conditions. Days cash on hand is another area that we kind of continue to look at. It's kind of the hospital's ability to meet its obligations and pay its bills. So this is the number of days that you have cash and you're able to cover those expenses. If you look at our FY25 submitted budget, it's looking quite a bit worse than where we were in FY21, which was post-COVID. There was a lot of extra funding there, perhaps one-time funding, and so it's reasonable that we wouldn't be as favorable as we were in 21. But some of these are pretty troubling, particularly the 44 days cash on hand or 50, almost 56 days cash on hand. That means that we have just over a month and a half, under 2 months of cash ready to cover bills. Really under 100 is kind of concerning. There's only kind of 3 months of wiggle room. On the other hand, some of our hospitals like Mount Ascutney are doing quite well. NMC, Rutland, when you're kind of in the 200s, that means you're much better off. Age of plant is something we also need to take into consideration. We don't need to have all the fanciest equipment, but we want to make sure that our facilities are being maintained and are factored in to what we're kind of modeling as expense growth over time. And so tracking that in relation. So you'll see, there's quite a bit of variation across hospitals, with some hospitals kind of staying in more recent years on the lower end of the scale, or the higher end of the scale. Similarly, long-term debt to capitalization is looking at kind of your debt financing strategy. There's, again, a lot of variation. So different hospitals have different access to capital and are better able to take advantage of certain kinds of financing opportunities. Operating expense growth. So this is looking at cumulative operating expense growth from 2021 to 2025. So it's like, how much have you grown over that period of time? We're trying to find a way to visualize this for everyone all at once. And what you'll see is that there are a couple of hospitals that are kind of at the higher end of the spectrum. So UVMMC, Copley, and Grace Cottage have seen quite a bit of growth. Porter Hospital, at or above 50% operating expense growth over that period of time, which is quite substantial. Whereas you have some on the other end that are much lower growth in terms of their expenses. Labor expense growth, you'll see there are quite a few, labor expense is a challenge, but some have quite a bit higher labor expense growth from 2020 than others. This could be a factor of their size. So there's probably, as we move forward, we'll look into this a number of ways. But another area we know is driving some of the operating expenses. Traveler expense, we don't have traveler expense data for all our hospitals, so we're showing you what we received here. This is kind of another area we want to kind of dig into going forward and have better reporting and templates and more consistent reporting so we can understand how our reliance on travelers is changing over time and where that's happening. Certainly there are a lot of vacancies and there's probably good reason to have travelers, but I mean, I think as a long-term strategy, we certainly don't want to see continued reliance on travelers. It's more expensive and oftentimes is not as great for kind of patient satisfaction and quality. Capital expenditures are another area, as I mentioned, that we'll kind of need to monitor as a major driver of operating expense growth is, how much infrastructure you're building and how much equipment you're kind of adding to your portfolio. So we looked at capital expenditures as a percent of gross operating revenue, but again, we'll dig into that more as we move forward. Pharmaceutical expenditures are another area. So looking at kind of variations in who's able to manage that as a percent of their gross revenue and kind of learning from peers or entering some of these kind of more collaborative purchasing arrangements may be ways that hospitals can move forward and look for efficiencies. I'm not going to read this giant table, but just wanted to flag for folks that some of the data we collected this year is going to help us kind of understand some inherent assumptions. And this is where, staff have delivered questions back to hospitals to try to understand some of the assumptions inherent in their budgets. So for example, while the guidance is really about the commercial price growth from 24 budget to 25 budget, we also want to make sure that, the assumptions for the other payers make sense and are baked in. So, some have a Medicaid price assumption, and I just want to understand, is that from New York? Is that from Vermont? Does this make sense given your patient population? Or if you have 0% growth for Medicare fee-for-service, why is that? Some of our hospitals are reimbursed based on that PPS growth. Some of them are reimbursed based on cost plus. So we just want to make sure that we understand those assumptions. Another set of assumptions that are really important is really around volume. So are the assumptions you've baked into your budget on volume reflective of, are they more aspirational or are they more reflective of historical trends? What does that mean? So can we have confidence that the budget you've submitted is achievable? And then payer mix shifts, are the payer mix shifts kind of baked into the budget reasonable, and do they make sense? There's some here that are 334% growth in Medicaid. I would want to understand that and why that would be baked into the budget like that. So those are things that we'll continue to look at. I'll highlight some next steps and then I'm happy to take questions. So later this morning, we'll hear from Tom Reese, and then this afternoon, we'll hear from Rand, Bartholomew Nash, and Nancy Kane. So we're hoping to have a discussion about, different data sets and trying to understand high price, low price, volume, what are the ways that we should really think about controlling healthcare spending? What are the tools that we have to ask questions and try to understand justifications for higher budget requests? Then, starting tomorrow, we'll kick off our first hospital budget hearing. We'll have hospital budget hearings every couple days over the next several weeks, where hospitals will present their budgets and outline their justifications for those requests. And then we'll come back and staff will kind of review what we've heard and kind of focus the conversation, analyzing justifications, and then kind of land on some recommendations. And hopefully we can get to some decisions by September 15th, which is our deadline in statute. I did want to highlight that we are working on it. It's live already, so you can go there, but we're kind of trying to consolidate all the resources and all the data sets and analysis and reports that you may find useful throughout this process in one single location. So that link on the bottom called FY25 Professional and Staff Analyses is where we will be posting that. So there are already some kind of Tableau dashboards that use existing data that are there, just describing kind of patient trends and volume and access and quality. But we'll be adding more budget specific materials and reports there, including some of the stuff that you'll hear about later today. So that's what I have for you, but I'm happy to answer questions.
Thank you, Ms. Berby. No questions from me. Any other board members? Okay, great.
Thank you.
Hearing none, we appreciate that very much. Next we are turning to Mr. Reese, is that right?
Yes, and I believe I will share his slides. So if he's here, I can pull those up.
Why don't we take a quick 6-minute break and transition over? So we'll come back at 10:12. I need to make a quick phone call, and we'll resume at 10:12 with Mr. Reese, and we can put up his slides prior to turning to him. So 10:12. Thank you. I'm getting some feedback from someone's mic. It looks like, yeah, thank you. Mr. Reese, are you here?
I am here.
Hey, good morning. How are you?
I'm doing well, thank you. I apologize for the background noise, but they're working on the water system up the street, so I hope you can't hear that.
No, we can't. Okay, and I see the slides. All right, so we'll go back on the record, Maggie.
Back on the
So
record.
thank you. So in my time at the board, one of the things that's really amazed me is the public engagement and participation. Every week we have a hearing, there's a large number of people who come who are just from the public, concerned citizens who share worries about the Vermont healthcare system. And a lot of people participate, sending us public comment every day. Last night we had an incredibly robust turnout for the presentation from Oliver Wyman. And an incredible discussion ensued about some of the challenges and problems. And I find it really incredible how much people care about our healthcare system and spend their own time voluntarily working to help us make better decisions and to collaborate with us. And one of those people is Tom Reese. So I wanted to introduce Tom Reese. Tom is a healthcare consultant, and he's guided a number of companies on hospitals on system improvements. Tom consulted with the Green Mountain Care Board in connection with the fiscal year 24 budgets and did some analysis that the Care Board used and presented in connection with the 24 budgets. Since then, he's continued on his own voluntarily to commit his time to trying to help understand our healthcare system and identify opportunities for improvement. And today he will present some of those findings and analysis that he's worked up. I will note that Mr. Reese has certain data relating to the University of Vermont Medical Center. UVM does not agree with the entirety of his analysis or findings. He's met with them and shared this information, and UVM has indicated an intention to collaborate and help work through the data and evaluate it and work with Mr. Reese to see if they can further understand the information and come to ground on the findings. UVM is meeting with Mr. Reese later this week, I believe Thursday or Friday, and we'll continue to work with him to see if they all agree on what the data is. UVM may respond to these findings during its hospital budget hearing, which is scheduled for August 28th. The only other thing I would note is that healthcare data often needs triangulation. The numbers have a lot of context and explanation that's needed. And as somebody who analyzes and makes decisions based on healthcare data, it's really important to look at it all directionally and in context. So with that in mind, I want to turn to Mr. Reese and thank him for his time and commitment to the state. And we look forward to the presentation.
Thank you, Chairman Foster. That's very kind of you to give me that introduction. And as a way to begin, I'd like to place one caveat on the data I'm going to bring to the board today. And that caveat is that I'm actually come to you as an individual citizen. I have had the pleasure of some experience in healthcare that is kind of unique. But as a private citizen, I have deep interest and growing concern about the healthcare delivery in the state. But I do approach you as a private citizen. I began my analysis of data from the University of Vermont Medical Center probably in late or mid 2022. And I used the data set that I have commonly used in my hospital performance improvement practice called from the American Hospital Directory, which is a recapitulation of Medicare data. Since that time, I've actually developed several dozen views of many hospitals in Vermont compared to hospitals with similar size, similar location, but have spent the most amount of my time looking at the medical center because of its position in our healthcare system. This morning, I'd like to share with all of you one of 4 views that I've crafted based on the end of September data, end of September 2023 data, available from 2 sources. The first source is the American Hospital Directory source, but the second is a data set produced by the National Academy of State Health Policy, NASHP, that is very robust, very powerful, and I think has the great advantage of being accepted by state Medicaid agencies throughout the country. So one view I'm going to bring to you today is of 46 similar academic medical centers in the United States. The others views that I have developed extend from as few as 12 academic medical centers, which are comparators. The University of Vermont likes to compare themselves to the 44 best USA hospitals, to 30 university-based academic medical centers that are as close as I can get to the University of Vermont Medical Center. So with that introduction, I'd just like to walk you through this presentation and then leave it open for questions at the end of that. So this morning, I'd like to share with you just briefly a profile of the market dominance that we face and the board faces in regulating the state's hospitals. I'd like to walk through a very detailed comparison of these 46 hospitals compared to the universities. I also prepared a couple of slides justifying managing hospitals to Medicare as a base financial measurement standard. And then I'd like to finish with running through a couple of hospital examples that I find particularly interesting and germane to me. So could I have the next slide, please? So this is an overview of through September 2023, the last 12 months of total expenses by our hospitals in the state of Vermont. There are, I think, 3 pieces of this that to me were in fact a bit surprising. First, at the bottom, the 2 things that the numbers at the bottom that were surprising to me was it's the first time that I have been able to look at the total amount of dollars expended by Vermont hospitals over a 12-year period of time, and it's close to $4 billion, $3,780 million. Out of that, 54.5% of it, or $2 billion, was spent at the University of Vermont Medical Center. When I first started looking at this data in 2022, that number was $1.5 billion. So the growth of that is pretty spectacular. The one addition that I would make to that is that if you roll together the UVMC numbers, the Porter numbers, and the Copley numbers, which are entities of the network actually controlled $2.4 billion worth of that total expenditures, and thus represent 65% of the total dollars spent on hospitals in the state. Next slide, please. So here is the profile of 46 academic medical centers, and it's really in 4 different boxes. One box being how they generated revenue compared to their comparator hospitals, what their cost performance is like, what their quality performance is like, and what the reduction opportunity might look like if in fact they manage to three different scenarios. One managed to Medicare, the second managed to the group mean of these 46 hospitals, and the third being managed to gold, which I will explain when we get to that point. But the top box is in fact revenue generation, and it represents to me the singular most poignant example of what's happened to the affordability of healthcare in Vermont over a period of time. Now, these are one set of numbers. These are 2022 NASHP numbers. But the joy of the NASHP database is that it goes back for 10 years, so that it has 10 years worth of hospital data for every hospital in the country, whether that's a major medical center all the way down to critical access hospitals. The most important pieces for you are the University of Vermont line, which reflects the losses they have incurred from Medicaid, Medicare, and Medicare Advantage over the last 12 months, more than that now, but over the last 12 months of this analysis, and its impact, which is covered by commercial operating profit or margin. If you look at the relationship between the comparator hospitals and the medical center from a revenue perspective, the medical center generated 5% above average profit. But if you look at adjusting that profit for their volume, and I have used, and most analysts and healthcare data use, adjusted discharges. Adjusted discharges are basically inpatient discharges adjusted for outpatient volume. So the two pieces are very important in looking at comparative data. But if you look at the commercial profit per adjusted discharge at the medical center compared to their group of 46, it's 46% higher from a commercial perspective, and from a total profit perspective, it's 55% lower. So the interaction of the commercial payers with Medicare, Medicaid payers are certainly demonstrated in the profitability of the medical center and the impact on commercial rates. Second piece of this is cost performance, which is particularly interesting because it reflects the core of the problem that I believe is above in the commercial insurance. Working through each one of these boxes, cost per adjusted discharge is in fact, medical center is 15% above its comparator group. If you look at the direct patient care FTEs, it's 15% above the comparator group. If you look at the direct patient care labor cost per adjusted discharge, and thus the direct patient care labor hours per discharge, those numbers seem to be somewhat out of sync in that the direct patient care labor is 20% higher and the hours are only 12% higher. All of this data work that I've been doing is in fact learning from data. That's what I love doing. That's what I've done for many, many years. And sometimes things happen along the way that you don't anticipate happening. And one of those things happened this weekend to me when I actually was working on a data set for Copley Hospital. And suddenly, when looking at the boxes of the NASHP data, which are four basic boxes, one is inpatient services, the second is ancillary services, the third is outpatient services, and then there's a fourth of general services, which is both mainly administration and general services. In looking at Copley, I suddenly discovered that out of 30 comparator hospitals, critical access hospitals, they had the highest expenditures in outpatient services of any one of the 29 hospitals I compared them to. And that they spent $19 million in that 12-month period of time on those outpatient services, which startled me. And I had also two other comparator hospitals in that group that were Vermont hospitals, and those hospitals were also high in that outpatient services bucket. So I went back in and looked at the data set that I'd been working on, and actually the University of Vermont Medical Center is very, very high in that box. As a matter of fact, of the 5 comparator hospitals I'm going to talk about in a few minutes, it was by far the highest. And when I've fractionated that data, what's driving that up is a box called clinical services. And I need to work with the medical center on what is going into that box. Because it basically is a $173 million box that I can't really resolve in my own mind of what that is in that particular area. So there's in that particular box, you have $179 million. If you look at the total operating management cost, labor management costs, which are some 33% above the expected for that particular box, we begin to get a picture of perhaps 2 areas in which the medical center is far above their comparator groups. One being the services, outpatient services defined as being clinical, and the second is the management administrative services, which are substantially higher than expected. That results in a Medicare case cost that's 24% higher than their peer costs, and we'll come back to that in the next slide. Relative to quality performance, their Medicare performance score is a little bit above average, and yet I can remember that score being at 30 at one point in time, which is now down to 19. At one time, the medical center was a 5-star rated institution, and it's now down to 3. Their case mix is coming up a little bit, case mix being the mix of patients and severity of those patients. But it's still 11% below the 46 peers that I've looked at. And their percentage of patients, Medicare patients that die continues to be acceptable and very competitive. Looking at what this data tells to me, it says to me the medical center has potentially 3 opportunities to become more efficient. One is if they manage to Medicare, which is, as you will see, within this group, if they managed to Medicare, it would have been a $194 million change. If they managed to this group mean, it would have been a couple $100 million worth of change. And if they managed to the gold standard, and I use as a gold standard Geisinger Medical Center in central Pennsylvania, an institution that I know very, very well and actually spent some time there on their executive team. And they're a very efficient system, rural system, And compared to them, the net medical center would have had a $270 million opportunity. So let's move on to the next opportunity, which is talks about managing to Medicare. Aina, can you move to that slide, please? Thank you. I'm not going to spend a lot of time here. This is a profile of the Medicare margins generated or losses generated by all of the hospitals in Vermont in 2021 in accordance with the NASHP data. It's concerning because it represents $365 million worth of losses that, in fact, are being, in essence, made up on the backs of commercial insurance rates. You can see what each one looks like. Critical access hospitals are actually on a cost-based basis on Medicare, so they show all those numbers are positive. But they do lose money. Critical access hospitals lost about $21 million in 2021, with substantial losses from the full-service hospital component. If we summarize that data, go to the next slide, please. Vermont, in essence, has a $350 million opportunity if all of its hospitals targeted managing to Medicare reimbursement as an objective. UVM represents almost $254 million worth of that target. Of special note is that of the medical centers, the academic medical centers that I have looked at, and there are 100 of them, 72% of those academic medical centers actually in the last period of last 4 years, in accordance to the NASHP data set, generate 72% of them had a year that they either broke even or generated a margin from Medicare. So we can go to the next slide, please. So in summary, that concept of managing to Medicare is one that has been the foundation for many, many hospital systems throughout the country. I've spent the last 3-4 years working within the Ascension Health System, the largest Catholic health system in the world. And the objective for all of their 140 hospital CEOs is to manage the Medicare. That's the baseline. That's how you, as a CEO of one of their hospitals, performance is measured on your ability to do that. So it's not a target that's unheard of. It's a target that's realistic. And in fact, there is a major academic medical center in the country, the Cleveland Clinic, that has hospitals in both Ohio and Florida, who are in the process of figuring out how to manage the Medicare because they believe that's an objective of their system into the future. So enough said on that. I want to move to these last 2 slides, which in fact, can you go back to the slide before, please? These hospitals I have chosen to compare the medical center to in finite numbers because I know them very well. And as I said, one of them, Geisinger, I actually was employed by. They are similar academic medical centers. 3 of them, Vidant, Geisinger, and Emory are in fact got two of them, Vidant and Geisinger, are in the comparator group for the medical center. They like to compare themselves against the 2 out of the 12 that they compare themselves to. So they're an important mix. Two things that are really critically important. Number one, their number of discharges are in fact substantially higher than the medical centers. Their case mix index, as we knew, is a bit lower. But their case mix adjusted Medicare costs are 30% above. And when we look at their inpatient routine gross salaries divided by their adjusted patient days, they are spending 29% more on adjusted inpatient days than their peers. So there's one perspective. The second perspective, and this is one we've talked about before, their administrative and general expenses are substantially higher than almost all of the academic medical centers in the country. In fact, I think there are 5 that are higher than the medical centers on a adjusted discharge basis. Those pure costs are 400% more than these 5 academic medical centers that I know very well. And similar to that, the ratio of administrative and general services to the inpatient cost services are almost 500, well, a little bit over 500% higher than this group of 5. They're different than the group of, certainly different than the group of 46. But these are 5 hospitals that I know have worked hard at making themselves very cost efficient and have been very successful at that. I also looked at the square footage for each one of these institutions to see whether there was some interesting data there. I think there is an interesting conversation to be had with the bottom line, which is the ratio of general services to patient square footage, general service square footage to patient square footage, which is much higher for the medical center percentage-wise than it is for its peers. So that's an area of further musing from my perspective. This last slide I'd like to share with you, which is the next slide, is a micro analysis of those numbers, those administrative and general services numbers. But I was really interested in looking at these 5 hospitals and, in fact, comparing their average salary component with the medical center's component. And I was stunned that there is no difference, in fact, between these 5 hospitals in any of the buckets. Maybe there's a little labor overhead costs are 4% higher at the medical center, but in essence, these hospitals are paying their employees about the same on average. And so there's not a salary difference here. These are in people numbers, and it's the numbers of employees that are present in the administrative general services bucket at the medical center. And that total general services bucket is basically 120% plus above these other 5 hospitals. The administrative and general services is 400% above them. And that represents a considerable portion of the general services bucket. And the total patient service salaries are in fact substantially lower across the entire spectrum of the other 5 hospitals. So in summary, I guess what I'd like to leave you with is the following. I think the University of Vermont Health Network represents a regulatory challenge. It is a monopoly. It is comparatively overexpensed, and most specifically, it's overexpensed in at least management and administration, and maybe in outpatient services, depending on how they are bucketing that and populating that service line of clinical services. This results in unique pressure on our insurance carriers, certainly our commercial insurance carriers, and also reflects, in my opinion, the fairly rapid decline in affordability of those commercial insurance premiums. Those pressures have spilled over into other areas of our economic structure. Specifically, they're having a deleterious effect on our school systems, and the amount of money spent on school systems to build a mental health system component that can help solve that problem, but also an insurance component that the schools have to pay for their employees' health insurance and retired employees' health insurance. There may be a $300 million opportunity by managing to Medicare. There seems to be a substantial opportunity in non-clinical salaries, plus clinical salaries in the outpatient services bucket. And there seems to me to be an endemic problem in the cost of those outpatient services that needs to be addressed. Thank you for your time and for the privilege of sharing these observations with the board. I would love to answer any questions as best I can and go from there.
Thank you very much, Mr. Reese. It's an immense amount of work, and I really thank you for putting in all this time of your own time, uncompensated, to do this for us. As we've been hearing in the Act 167 process, the state's healthcare system is at a serious tipping point, and we need to find opportunities wherever we can to maintain our system and ensure that the system is affordable for Vermonters. Something that Dr. Hamre's work has revealed is the importance of managing to Medicare. So this dovetails with that critical component of operating our system, and that where we are in commercial prices, it's going to be more and more imperative every single year to make sure we actually are managing to Medicare, especially given the demographic challenges that we have in the state and the severe spike in the plus 65 category in Vermont, who is obviously paid by Medicare. So this will be more and more important as that commercial market shrinks in Vermont, and we've exhausted commercial opportunity here. So thank you for your time, and thank you for working with UVM and meeting with UVM to see if there's areas of alignment or disagreement or to sharpen the focus on this data set. And we owe you a huge thank you for doing all of this, really just as a concerned citizen who cares very deeply.
Thank you for that. And I hope that this data is hopeful. It is opportunistic data. It gives us a hope that we can start moving and shifting those expenditures on hospitals out into the community, into primary care and behavioral health components that could be really, really important to us.
I had one question, and I probably will have others at another point, but one question I had was on the Medicare star ratings.
Yes,
I know that UVM was a 5-star rated hospital, and I had thought it was now a 4-star, but your slide had it as a 3-star.
it's a 4-star now.
Correct?
No,
It's a 4-star now.
It is 4-star now. It was a 3-star back when that piece of data was produced. Yes,
Got it.
it's
Okay,
correct.
Thank you.
Thank you.
All right. Any other board member questions or comments for Mr. Reese?
I have just a couple, if I could. Mr. Reese, thank you, as Chair Foster said, for all of your work on this. On one of the early slides, you had Medicare and Medicaid losses
Yes,
listed that were some over 3,000% different from the comparison group. Later on, you had administrative and general expenses that were 400 to 500 times higher than, or not times, but 400 to 500% higher than the comparison group. Are those numbers related? And if so, how?
I believe they're related, and in my professional experience, I've had this conversation many times with many CEOs that the relationship is in fact opportunity to manage towards Medicare, but that opportunity has to be managed carefully, and that opportunity has to be dedication to cost efficiency in your organization.
I'm in now. I'm
and,
in now.
and,
Okay, bye.
and a formal program at careful management of personnel and staffing.
And so I think I'm understanding the manage to Medicare. That's managing the business of the hospital so that there is you break even or there is a small profit on Medicare reimbursement level at Medicare reimbursement levels. What I want to try to understand is if administrative and general expenses are much higher at a facility, would that contribute to losses from Medicare and Medicaid reimbursement?
Absolutely, yes, without a question. And maybe I didn't explain myself as fully, but as a member of teams that went into hospitals and looked at academic medical centers and systems of hospitals, the first level of evaluation in any diagnostic is to look at opportunity. And there is an opportunity if, as a consultant, there's an opportunity in losses from Medicare, because you should be able to manage down to Medicare or close to Medicare. And that's the first place you would look is in administrative and general salaries to start managing down to that level, as opposed to looking to clinical services that are core to your line of business. So you look for low-hanging fruit in where there's excessive management services. Does that answer the?
Yeah, that's helpful. I just want to make sure that I'm understanding this point, because the size of the admin and general expense bucket in your later slide is something that is controllable. Those are decisions and choices about who to hire and how much to pay and how many to hire. And those choices then show up on your spreadsheet as Medicare and Medicaid losses. That loss is then just used to justify higher commercial prices by some healthcare organizations. So the need to demand higher prices from commercial payers, that sense of need to do that, part of that need is the result of choices made within the organization, if I'm understanding your data correctly.
That is absolutely correct. And those are choices made, as you said, on a day-by-day basis. And they're choices that can be made as the Cleveland Clinic has begun making. Those are choices made not driven by patient services, but driven by administrative decision. So their objective is to get down to managed by Medicare through reorganizing how they run their organization, and not clinically, but from an administrative and management perspective.
Again, thank you very much. That helps my thinking.
Thank you.
Any other board member question or comment? We have about 5 minutes left, and I have to run to another meeting at 11. So I'll turn to the healthcare advocate, and then we'll have time for public comment. The healthcare advocate.
I think Sam is not asking a question. Sam and I are chatting at the same time. So if that's true, I think I'll just say thank you, Tom Rees. Appreciate this presentation, and in the sort of interests of full transparency, let everyone know that Tom, I owe you an email that we need to figure out a time where we can sit down and go into some more detail than I think makes sense to ask right here. Also to let everyone know that the healthcare advocate will also sit down with UVM, have a plan to sit down with UVM and understand their perspective on the numbers as well. But again, thank you for your presentation. I think it helps the process.
Thank you, Mike.
And we can take public comment via the raise the hand function. Pam Davis.
Thank you, Mr. Chairman. I'd like to just put out another view here. I think that whole issue about the specific cost, the administrative cost at UVM, has got a huge error in it, in the sense that here's what I think it is, and I think it's obvious. UVM the UVM Health Network is a 6-hospital unit, a integrated system. But what they have done is, and maybe they should change that, but what they have done is they have put at least $200 million and 300 more north, almost 400 employees they have that actually deliver services to all of the hospitals in the network in both Vermont and New York. They are loaded in, for accounting purposes, entirely on UVMMC. That obviously skews the administrative cost of UVM, and I think that is really obvious. And I'm surprised that the staff of the Green Mountain Care Board hasn't been able to pick that up and make it obvious. Thank you.
Thank you for that point. I recall that being part of the discussion last year during the hospital budget process, and certainly something to come to ground to understand. So thank you for raising it. Mr.
Chair
Vincent
Foster.
from UVM.
I'm sorry.
Oh.
Chair Foster, I'd like to respond to that because we did look at that last year. And if it were true, we should see very high expenses at UVM, as Mr. Davis is suggesting, but savings at the affiliate facilities. And we do not see savings in those facilities.
Can I respond to that, Mr. Chairman? I don't know if I'm, can I respond to that?
I have an 11. I'd like to have Mr. Vincent have an opportunity to speak, and we don't need to get into some sort of debate. This will be something that will be brought up in the hospital budget process, and we'll certainly want to make sure we get it right, and we want to understand UVM's perspective. So I apologize. We have a second session this afternoon, but I want to make sure Mr. Vincent has a chance to speak.
Thank you, Chair. Just a quick comment. So we are looking forward to working with Tom to better understand the analysis and hopefully learn from each other. For Member Walsh, just to highlight where you can really kind of see this is in the presentation, and we'll definitely present more of this at the hearing. But if you look at the 5 organizations that are listed in one of the slides, so Geisinger, Emory, UPMC, if you look at that administrative cost there, you see numbers that are 23 million, 22 million, 39 million. That cost there is supposed to represent what they're spending on HR, IT, legal, executive salaries. That's what that administrative and general salaries number is supposed to represent. And, because of the way that, these sources pull cost accounting data, when you're part of a network, that isn't pulling in the network corporate structure. So there's no way that those organizations are only spending $20 to $30 million on all of those support services. Whereas when you look at that 150 million for UVM Medical Center, that is all of the services that are provided to support it.
Thank you, Mr. Vincent. Mr. Del Trecco.
Thank you, Chair Foster. Can everybody hear me? Okay.
Yes.
So appreciate the opportunity to talk. As you've heard me mention on more than one occasion, and I know that you and I personally have had some of these conversations, I think predictability on this information is important. I don't know whether this data is right, wrong, indifferent, directionally accurate, but I find it a little bit maybe dangerous to be presenting information before it's understood, reconciled. Again, I don't know if it's right, wrong, indifferent, and I ask very, very importantly ask that we have appropriate stakeholder engagement. I will not be at this afternoon's meeting because of a conflict, but once again, I ask for stakeholder engagement to look at this information, understand the information. If there are actionable things, we should be trying to do better, but I don't know if they're actionable. And I think that should be a goal of ours moving.
Great, thank you. Any other public comment? Okay, thank you, Mr. Reese and Ms. Barabee, and for everyone speaking. We have a 1 o'clock, so we will adjourn for now and resume at 1 o'clock. Thank you.